Hello everyone, today I'm gonna make a video of morphine sulfate. Morphine sulfate is an analgesic. It is under the category of an opioid analgesic. Opioid is like a drug like heroin or like whatever the substance is. If it's gonna affect negatively on stress or pain, it's called mainly called opioid. So morphine sulfate is the number one choice for PCA system. PCA is like the patient controlled analgesic they can get if there is a high pain rising like a breakthrough pain. They can actually click on the button and they can get a specified dose prescribed by the doctor and then set up by the nurse. They can get it, and they cannot just click on every time, and it's gonna have a specific interval, and then they can only get it after some time that is also set in the system. So they can actually click on it, and then if it's ready they will get it. If it's not ready, they can ask the nurse, and actually the nurse can actually talk to doctor if there is a need to increase the medicine, or if there is a need to do an alternative therapy, or like therapeutic touch, distraction, decrease to light, stimulus, things like that. Or we can add a substitute, or like we can add a supplemental medication with a more morphine. So they can discuss all these things when they are doing the interdisciplinary round. So what is morphine sulfate do in our brain, in our system? So it's in the morphine sulfate, there's like receptor sites in our spinal cord, the upper level of spinal cord and central nervous system. Okay, there is this receptor sites that this morphine can bind to. So what are they gonna do together is like they're gonna slow down the system. So now the respiratory center in the brain, the pain sensing center in the brain, the whatever it is, the stress anxiety sensing things in the brain, it's all gonna slow down. So what happens is like we're gonna have like less respiratory drive. That means we're not gonna breathe as fast as we used to breathe without morphine when we are in like high dose of morphine. So we always monitor the patient's breath. We cannot administer morphine if the patient's breathing is less than 12 per minute. If it's less than 12, we cannot give. If it's less than 8, that means the patient is not gonna have enough oxygen, because patient is not breathing, and also the carbon dioxide is gonna rise up. Then it's gonna cause like respiratory alkalosis and stuff like that. So we don't want to go there. So always monitor patients breathing whenever they are on morphine, and also if they are not breathing at least 12 breaths per minute, we cannot administer morphine sulfate. Also, it can affect the anxiety level and the stress level of the patient. That's why people get more addictive to this drug. And also people can build up the tolerance by the time, by the time goes by, they can build up the tolerance to this medication, and they may end up needing more dose of this medication. So the thing is like, maybe my body is different than the other patient's body. Maybe my body only needs a little bit of morphine to do the effect that the doctor wants on my body. But the other patient's body, they may need more dose of morphine to have the result that the doctor wants to. So it all depends on the patient's body. So we need to monitor the patient, we need to assess the pain level and see which patient needs more dose, and which patient needs a lesser dose, because all the patients body are different. Everybody's body is different. Everybody's body take up the morphine differently. Everybody's liver is metabolizing the morphine differently. So it is always we need to monitor all the patients like individually. This morphine can help the people with moderate to severe pain. So but if the dose is little bit higher for them, they can go to sedation, they can go to like less respiratory drive, they cannot breathe, and then they can go to coma, or they can go to alkalosis. So we need to monitor them. So why a the chest pain patient coming to hospital also get morphine? Is it for just for pain? No, it's not just for pain. So whatever, now if patient with myocardial infarction, the muscles, the heart muscles are not getting enough oxygen, because the coronary artery is now either blocked or hemorrhaging, and the muscles are not getting enough oxygen and the muscles are dying. So the main priority of a doctor for the patient having myocardial infarction is to save that muscle so the heart can work a little bit better for some more time, So morphine, what morphine is gonna do is like morphine is gonna decrease the anxiety, decrease the need of oxygen of a tissue, of that muscle tissue. So they can work a little more time with less amount of oxygen. Morphine is gonna slow down the system. Morphine is also gonna slow down the metabolism. So when morphine is slowing down the metabolism and the patient is on morphine for a long time, they can have constipation, they can have urinary retention, because now morphine is slowing down the excretion as well. Also, we need to monitor the electrolytes level as well, and the liver function test, because morphine is metabolizing by the liver, so we need to know, what is the status of the liver. Morphine can decrease the blood pressure. So when patients are on morphine or any pain medication, so you need to let them know, okay, if you're lying down on the bed, if you want to stand up, just sit on the edge of the bed and then dangle your legs and see if you're feeling dizzy or something. If you're feeling dizzy, do not get up, call use the call light. The nurse can come and help you to get up from the bed. So orthostatic hypertension can occur. That means, by the position changes, the blood pressure can vary. So that means if the blood pressure goes down, the patient can feel dizzy, and then patient can fall down from the bed. So we always educate them, do not get up without, if you're feeling dizzy, just let us know, we can help you get up. The same. So like I said, we need to assess pain and vital sign and respiration. If it's below 12 breaths per minute, we cannot give morphine sulfate. And infants and older people are more tend to have the less respiratory drive. They can easily go to sedation and have hallucinations, or whatever it is, they can easily go sedation and go to coma. So we need to monitor them more carefully than any other adult. And what if there is like a overdose occurs, a morphine overdose, like any opioid overdose, we can give naloxone. The other name is Narcan. We can give that, and that's gonna give a negative effect on morphine, and that's gonna help the patient to come back. So naloxone, that's we need to remember that naloxone or Narcan is the antidote for morphine sulfate. And we need to document whatever we are assessing, and when are we giving morphine, after, before giving and after giving, 30 to 1 hour, we need to assess the pain. Also, it's a narcotic, so we need to have a strict numbers, we need to have a strict calculation. So the charge nurse or whoever is assigned to do it, we need to count the narcotics every shift, and then, if there is any discrepancy, we need to fix it before the start of the next shift. So that can involve with the pharmacists, with the doctors, with the nurses, because it's an addictive drug, and people can abuse it, people can use the drug, and then so if there is a discrepancy, that needs to be corrected before the next shift. By time going, the patient can feel, okay, this is not effective, because now the patient has built up the tolerance towards the drug. That means the patient needs more dose for this drug, or patient needs to have changed to another drug. If they are going to coma, how do we know, if they are, so we need to assess the respirations each minute, and also we can actually look with the what is it called, the look with the light, the pen light, and see the pupil. If there is pinpoint pupil, that means the patient is going to coma. So that is like a neurological emergency. Seizures, asthma, severe respiratory depression, I already told you. So asthma, some people, their cells does not like this morphine, or the broncho receptors in the lungs can actually get affected by this morphine, and they can actually constrict the bronchus, the bronchioles. That means that patient is not gonna breathe, they're gonna start wheezing, the lungs is constricted now, so that is asthma. So it can trigger asthma as well. That means that patient needs epinephrine also. So it's like an emergency situation. So before giving morphine sulfate, we need to ask them if they they had any reactions with the prior use of morphine or any pain medication. If they can remember and tell you, that's a good thing. So you can actually tell the doctor, and then we can actually think about alternating the medication or things like that, because we do not want this patient to go to an anaphylactic shock. When they slowing down the brain, so if there is a hemorrhage in brain, the ICP, the intracranial pressure, that means the pressure inside the cranium is gonna go up, right? But the patients that are in morphine, it goes up, but it always slowly goes up. That means, it can mask the ICP. That means we need to really carefully watch the ICP when the patient is on morphine, because we cannot, if you depend on counting the ICP, that may you can see the ICP going up later than a patient who are not on morphine. So it's a controlled substance here, so you need to monitor the count as well as the patient status. And it's a morphine sulfate, so addictive. So you need to actually wean off the, actually do not encourage the patient to use morphine. Use the alternative therapies, like use distraction, use like therapeutic touch, use other pain medication first, and then go to this morphine. So this should not be the first choice. Start them with like Tylenol or whatever the doctor prescribes first, and then it should go. That's the purpose of assessing the pain of the patient, because so we need to know, like, what is the, if it's like 6 to 10, that means the patient is in moderate to severe pain. So if it's like less than 4, the patient does not need a morphine or any other like this kind of severe pain medication. So narcotics. So we need to actually, that's the purpose of assessing the pain, and you need to let them know, the zero pain is not possible, but we can actually help them have a relief with their pain, so we can work on it. So always start with a small dose, always start with this the the low dose pain reliever. Also, yeah, that's all about morphine sulfate. I know it was a lot information, but I did not go elaborately on morphine. I just told you the quick review for morphine sulfate if you are preparing for NCLEX. Thank you for watching, and keep on watching this channel if you want more NCLEX related or any kind of videos. Also, I don't have a genre, so I will upload more kind of videos. And please subscribe. If you click on the bell button, you will get all the notifications and topics about the videos that I'm posting. And if you're interested, you can actually click on it, so you won't miss anything. And also, if you comment and like, I do appreciate it. And thank you for watching once again. Bye.